Hello, I'm Jonathan Kay from the University of Massachusetts Medical School in Worcester. Welcome to the Room Now Rheumatoid Arthritis Faculty Panel from day 4 of the ACR Convergence 2020. We're all sitting in our home offices after having spent 3.5 days in front of our computer screens, not moving and taking in lots of great information about rheumatoid arthritis and other topics. I'm joined today by Kathryn Dao from Dallas, Texas, Meral El Ramahi from Cleveland, Ohio, Dein from Baltimore, Maryland, Richard Conway from Dublin, Ireland, and Sheila Reyes from Manila in the Philippines. We're recording this a little bit earlier than we have the previous days, so Sheila is only being forced to stay up till a little after midnight in the Philippines, and Richard is still during waking hours in Ireland. So I look forward to a very lively discussion today on this last day of ACR Convergence 2020. How are you all holding up so far?
Very good.
Blue filter glasses.
So it's a tiring experience spending the entire end of last week and the weekend and Monday, and then going back to work to see patients the rest of the week. So there have been some good abstracts today. I guess, Meral, you were looking at the abstract that was presented about methotrexate and hydroxychloroquine comparing cardiovascular mortality.
Yeah, I know there are a lot of exciting things that happened today, so I just want to briefly mention this abstract. It's abstract 1993 titled Cardiovascular Risk in Rheumatoid Arthritis Patients Treated with Methotrexate versus Hydroxychloroquine. It was a large observational study of about 23,000 patients enrolled in Medicare with RA. And they studied whether or not there was a difference in initiating hydroxychloroquine versus methotrexate in these patients in terms of major adverse cardiovascular events. And there was in fact no difference detected in risk of MACE between patients who either newly received methotrexate or hydroxychloroquine. In a secondary analysis though, they did note a difference in terms of there being a greater stroke risk, but a lower risk of MI and heart failure hospitalizations in those who are initiated with methotrexate.
Those are intriguing findings because of the increased risk of stroke with the lower risk of myocardial infarction, and I think it was heart failure. So this is sort of a paradoxical response in terms of cardiovascular disease. This was a claims database, so unfortunately they couldn't look at CRP reduction, which might have been differential among those patient groups. So it's a very interesting abstract from a very productive group at the Brigham and Women's Hospital in Boston. Who has another abstract that they want to talk about?
I could go.
Okay.
Actually, this one might actually change your practice. So this is a late breaking abstract presented by Kevin Winthrop. And it was a matter of, do we really even need to hold tofacitinib if a patient gets the flu, right? So it's a post hoc analysis, almost 8,000 patients. So these were patients from phase 1 through phase 4 trials of tofacitinib. And they were comparing tofa 5 and 10 milligrams BID as monotherapy or in combination with DMARDs and in comparison to adalimumab, methotrexate, or even placebo. And they followed these patients for 14 to 15 flu seasons. And basically what they found was that the incidence of flu is the same across the board. And not only that, most of them were mild cases. And then the zinger here is 70% of patients actually stayed on their tofacitinib. They didn't discontinue it during the time that they got the flu. And when they compared the patients who stopped versus the patient who continued, they found there was really no difference between the two in terms of the final outcome. So for me, if a patient got the flu, and I guess if you confirm flu and it's not COVID-19, I would say you can still continue tofa.
There were some abstracts about COVID-19 and continuation of anti-rheumatic drug therapy, and so far it doesn't look as if continuation of anti-rheumatic drug therapy, even if it's COVID-19, has much of an adverse effect. Eric, you had an interesting abstract about diet.
Yes, we've spent a lot of time over the past few days talking about rheumatoid arthritis in the lungs, so I thought we should balance it out with the gut a little bit. So this is actually the abstract right after Meral's I was presented this morning, 1994. And so this was RA improvement after exposure, anti-inflammatory, the ITIS diet, is associated with changes of gut microbiome and systemic metabolome. So this was a study out of UCSD. The thing to note about the study is it was an open label pilot trial. So it was a 2-week kind of proof of concept trial of the anti-inflammatory itis diet. So not a gluten-free, but a anti-inflammatory diet and emphasizing the pro-inflammatory foods as well. So they had 17 patients with active RA. So they had to be pretty active, at least 3 tender and swollen joints to be in the study. They followed them with fecal and plasma samples during the study. And they found that 11 patients responded, 6 patients did not respond. And patients for the 2 weeks they were on this diet, they adhered to the diet. Their pain went down from pain scores of about 4 to 2. CDAIs went from 29 to 12. But what was interesting was they found quite a change in their fecal microbiome and their metabolome changes that particularly the patients that were documented in that responder group seemed to have clear changes in their microbiome, and that made them think as well that not only the diet journals that they made, but also the changes in their fecal composition was an encouraging thought that there's something actually happening, and that's correlating with the clinical response. So again, it's just a short study, but it's kind of an interesting idea moving forward.
So those are interesting findings. Certainly, you would expect the dietary change to perhaps change the microbiome, and we know from the work of Jose Scher and others that the microbiome has an effect on development of rheumatoid arthritis. The problem with this study is that it was open label, and given a diet with the expectation that it might have a beneficial effect on rheumatoid arthritis disease activity, you're likelier to see that beneficial effect without a control group. So it would be interesting if there were a controlled diet or some way to blind the subject as to what they were eating, although that's tough. But an interesting approach. Another very interesting non-pharmacologic approach to treating rheumatoid arthritis was presented from a group in Europe, I think it was the UK, wasn't it, Richard, where they looked at
it was in Barcelona in Spain.
Barcelona, that's right.
This is abstract number 1995, so going after 1994. And this was a study of non-invasive vagal nerve stimulation. Background to this was another study of an implantable vagal nerve stimulator that was published in Lancet Rheumatology this year by Mark Genovese. And in that study, they found with refractory RA patients that this implantable vagal nerve stimulator appeared to give some decent improvements in disease control, with a decrease in the DAS of minus 1.4. So in this study, they tried to improve on that, I suppose, by using a wearable device. It almost looks like a smartphone with a set of earbuds attached to it. So no need for an invasive procedure to put this in. Theory behind this is that you stimulate the afferents of the vagal nerve, and that goes up to the brain, and then it sends out efferent signals through the vagal nerve to the spleen, to macrophages and cytokines there, and it reduces inflammatory activity that way. So the wearable device with the earbud works on the principle of stimulating the auricular branch of the vagal nerve. So this was an open label study, no control arm, 30 patients in it. And what they found were quite similar results to the implantable study. So the DAS decreased by minus 1.44, ACR 20 of 53%, ACR 50 of 33%, and ACR 70 of 17% in these patients. They weren't quite as refractory a group as the implantable study, but they had previously failed DMARD and up to 1 biologic. So it's a very early pilot study, but a very exciting technology, I think.
Absolutely, and patients are more likely to be willing to participate in a study of a wearable device rather than an implantable device. The study that was presented by Norm Galis last year at the ACR meeting with the implantable device they had a group of patients who were treated with the device not hooked up. So there was an external stimulator, and they essentially uncoupled the wiring so that they would try to stimulate it, but it wouldn't actually provide stimulation. And then they looked at the stimulation when it was active and actually saw differences. It would be nice if this group would repeat that approach to studying this wearable device. It might give a little bit more robust information about the efficacy.
I suspect that's probably what they're going to do next, and I would say it's a fairly easy thing to do. It's the same device, and you just don't turn it on.
Yeah, or you have a switch where they're able to control it remotely, because if the patient knows they're turning it on or not turning it on, then that unblinds the study. But I think you're right. That's probably the next step in the development. So just for those people who are probably dying to know what 1996 was, since we had 1994 and 1995. 1996 was Kevin Winthrop presenting data showing that pneumococcal vaccination is successful in patients taking upadacitinib. So just to follow up with 1993, 1994, 1995, here's 1996. So Sheila, what are you going to tell us about?
All right, so I'm gonna go back a bit to 1533. So it's a poster presented by the group of Dr. Yorktan from Singapore, where they did a cross-sectional study to assess the severity of joint damage in patients with RA based on joint inflammation on ultrasound or clinical assessment using the DAS. So this is an imaging study where patients were categorized into 4 groups, a combination of both power Doppler signals and grayscale, or the absence of one of each, or the absence of both of the parameters. And they were then compared and analyzed. And it was a total of 30 RA patients, and were predominantly female, Chinese population, with an average disease duration of 70 months, and majority were on conventional DMARDs. So their results showed that the severity of the ultrasound detected lesions was significantly greater when both the positive power Doppler signals and a greater degree of the gray inflammation was present. And this was not observed when either of the components were absent. So again, this raises the question of whether ultrasound has a potential role in being able to identify RA patients with aggressive disease.
It certainly looks that way from the original studies coming out of Leeds back in the early 2000s, and subsequently the patients' ultrasound picks up subtle synovitis that's not yet apparent on plain radiographs, and certainly using it to detect patients who might have disease that would respond to treatment is a great approach. However, the Arctic study showed that use of ultrasound in a treat-to-target approach didn't add anything over good clinical examination. So its role in driving therapy is unclear, but certainly ultrasound is a great way to assess the joints and detect subclinical inflammation. So we've all avoided the elephant in the room. The elephant in the room today was the ACR 2020 management recommendations, which were presented by Leanna Frankel and then discussed by Joan Bathon and Stan Cohen with some examples. What are your thoughts? There are some differences there. It certainly comes out and advocates for methotrexate as the initial treatment, methotrexate over triple therapy, and methotrexate over leflunomide, adding methotrexate over an initial biologic or targeted synthetic DMARD monotherapy, and then switching to subcutaneous methotrexate before escalating beyond. They talked about pushing methotrexate to a maximal dose, but they didn't say, at least in the presentation, what that dose is. How high do you push methotrexate? Kathryn?
For me, I mean, I can go all the way up to 25 milligrams sub-Q weekly. I mean, I have no fear about that. It's just a matter of tolerance and also monitoring their labs. But yeah, I think that the ACR really did a good job with these guidelines compared to the previous guidelines. I mean, they are very strong and really pushing methotrexate with these guidelines. I mean, they're saying use methotrexate even if the patient has rheumatoid nodules. You're not going to, make these nodules worse. And if you do, okay, then you switch. Use methotrexate in patients with RA lung disease. You're not going to make the lung disease worse. Use methotrexate in non-alcoholic fatty liver disease. I mean, it's like methotrexate, methotrexate, methotrexate. So I really think that basically the ACR guidelines this year, I really liked it. They really didn't have one preference of a non-TNF biologic over another. They didn't have a preference saying which targeted synthetic DMARD they prefer compared to any other. So it kind of left a lot of open doors for clinicians, which in a way is good because whenever I have to write like an appeal letter, I want to be able to say, hey, the guidelines is saying this and I can choose whatever I want.
Absolutely. The first time the ACR came out with RA treatment guidelines, they were so evidence-based and there wasn't evidence for many things that they really were like Swiss cheese with lots of holes, and the practitioner had justification to do a lot of the things that we knew were justified, but not other things. Sheila, what are your thoughts?
Well, yeah, in this part of the world where methotrexate is really the first line of treatment with RA, especially since other biologics are either not available or very expensive. So physicians are given the confidence to use methotrexate in the various clinical scenarios that the RA patients have. So I agree with Kathryn in that these guidelines are better than the previous ones, and that you could apply it in your patients clinically, and hopefully it helps.
Yeah, they came down pretty hard on corticosteroids. When I initiate a patient on methotrexate, knowing that it's going to take a couple of weeks to start to have an effect, I'll typically give a tapering course of prednisone. I've gotten more aggressive, sort of almost doing a COBRA regimen. I start usually at 40 milligrams for 5 days, 30 milligrams for 5 days, 20 for 5 days, 10 for 5 days, and then stop. It's purely arbitrary and it's not based on any literature, but patients seem to feel better for that first month while they're waiting for an effect of methotrexate. But these ACR guidelines said that even 5 milligrams of prednisone has potential deleterious effects, and they really came down and said, don't use prednisone. Any thoughts? Meral, what do you do?
Yeah, I tend to adopt a similar style to you. I tend to put my patients on prednisone. I don't go as high as 40, but I'll go on 20 and I'll keep them on 5 milligrams longer. I don't stop them until at least 6-8 weeks in, or until they message me that they've noticed clinical improvement. So yeah, I was really appalled how hard they came on that from that perspective. And they also are advocating on not using steroids in someone who's had an infection within the past 12 months to modify the DMARD therapy as well in those instances. So we've always known the adverse effects of prednisone, but in this case, it would be practice changing for me to adopt that aspect of the guideline and holding off on initiating steroids with methotrexate.
Absolutely. And they also were favoring TNF inhibitors over targeted synthetic DMARDs. EULAR guidelines said either a TNF inhibitor or a targeted synthetic DMARD. But the ACR guidelines, I guess because of the longer experience with TNF inhibitors, as Mike Weinblatt advocated in the great debate, are preferred according to the ACR. Certainly easier to get prior authorization from third-party payers, except now AbbVie seems to make it quite easy to get prior authorization for upadacitinib as well. Eric, what are your thoughts about these guidelines?
I thought one of the other very notable changes that I think will be discussed a lot is the move away from triple therapy. That I thought it's interesting that in their explanation for patients that are on, again, kind of the subjective term of maximally tolerated methotrexate, the next move, if they're in active disease, would be a conditional recommendation to go to adding a TNF inhibitor instead of triple therapy. So triple therapy being methotrexate, hydroxychloroquine, and sulfasalazine. And so, I thought it was interesting because the recommendation was not that TNF inhibitor is more effective, that the data actually shows that they're equal efficacy. And I thought it's interesting because we know that triple therapy is certainly a cheaper option, but the conditional recommendation for going to a biologic therapy at that point is that, and it sounds like there was a lot of input from the patient advisory board on it as well, that patients seem to like it, they adhere better to biologics, and they and it has a quicker onset. But I thought it was interesting, and it changes, my practice. We've used quite a bit of triple therapy, and patients do, again, as well as biologics, and it's a much cheaper option. So I think that's just an interesting shift away for the guidelines.
Well, the study that Jim Odell published in the New England Journal showed that etanercept plus methotrexate was essentially equivalent to triple therapy, but the number of pills that a patient has to take on a daily basis is quite high. The guidelines didn't really go into what dose of methotrexate to use as a starting dose. I think when I started fellowship, methotrexate, we would use it at 7.5 milligrams weekly, and then gingerly escalate by 2.5 milligram increments. And by the time we were on 12.5 milligrams a week, we started biting our fingernails and practically had no fingernails if we had to escalate to 15 milligrams. Now I think it's pretty standard to start at 15 milligrams, and like you, Kathryn, I go up to 25 milligrams, either orally or subcutaneously. But more recently, I've been in some patients starting at 25 milligrams because patients usually tolerate it pretty well. There's European data to suggest that starting at 25 milligrams, you save time. You don't waste those 4 months when you're escalating by 5 milligram increments every 2 months. If the patient responds, that's great. If they respond inadequately, then you'll know to move on and add another agent. Richard, what are your thoughts? You're sitting in Ireland, where home of the late Barry Bresnahan and Doug Veal and other great rheumatologists. How do these guidelines strike you?
Yeah, I think I agree. Mostly there are a lot of good things in there, quite strong on methotrexate, but not in every setting. They're still, in people with lower disease activity, potentially advocating hydroxychloroquine or sulfasalazine first. It's very, very rare that I'd start any patient with rheumatoid on hydroxychloroquine or sulfasalazine first. I think there's a risk to doing that just because they don't have high disease activity when they come in and see you. If they've early rheumatoid, that you're missing that window of opportunity, treating them with a less good agent than methotrexate and letting the disease become more established. I completely agree with the strangeness of the steroid recommendation. I think it's cruel in a way not to give a patient with high disease activity some steroids, let them suffer for 3 to 6 months while methotrexate kicks in. I think giving that short course of steroid for 4 weeks maybe, getting the patient feel good can help a lot with adherence down the line as well. They really trust you when you can make them feel better. And that you give it the steroids for 4 weeks, it has a much longer effect a lot of the time, and keeps them feeling well while the other agents are kicking in. Again, methotrexate, I have increasingly increased my starting dose. I haven't quite gone to the 25 milligrams weekly yet. I do that in vasculitis a lot, so I don't see any reason not to do it in rheumatoid. With the JAKs and the TNF inhibitors, while the EULAR recommendations do put them on equal footing, it's incredibly unusual that a JAK would be started first here for cost reasons. Biosimilars mean that TNF inhibitors are much cheaper than JAKs, so it is very often still the TNF inhibitor first line that we'd use.
There are data with both baricitinib and upadacitinib that in comparative trials, both of those drugs, the the 4 milligram dose of baricitinib and the 15 milligram dose of upadacitinib were superior to adalimumab 40 milligrams every other week. So there are emerging data suggesting perhaps superiority of JAK inhibitors to TNF inhibitors in clinical trials in a very select population of patients that are not necessarily representative of the majority of patients that we see in clinical practice. So we've got these new ACR guidelines. They have some differences. I think they're more practically applicable than previous guidelines. And it'll be interesting to see how they're adopted by the community. I think they really reflect community practice as it exists now, but perhaps they'll help us justify accessibility of medications to third-party payers. Any closing thoughts? I'll go across from left to right, top to bottom. Kathryn?
Lines that actually talked about tapering, once patients are in remission. And what they said is that don't even think about tapering unless the patient's been treat to target remission after 6 months. And then you want to taper off methotrexate first. Although methotrexate is the first thing you use, it's also the first thing to go because they want you to keep, the biologics or the TNF inhibitor and, get rid of the methotrexate first. So I think that these guidelines are something that I can apply to my practice. They are very practical and gives us as clinicians the ability to take care of our patients very effectively. And also the ACR made sure, just like what Sheila said, with cost consciousness in mind, these guidelines were developed.
Absolutely. Meral.
Yeah, I think at the end of the day, it still emphasizes the need for shared decision making because although, triple therapy is more pills, there are some patients who prefer oral medications as opposed to injectables. And so I think it just comes down to having that discussion with your patients. But these guidelines are a nice structured platform to operate off of.
And they involve 10 patient representatives in developing these guidelines. So that was very thoughtful and very appropriate. Eric?
Yeah, I think along those lines, I think the shared decision making that so many of the recommendations that the ACR was able to make was a conditional recommendation, and that there's a lot of gray area that we still have room to figure out in practice what's working the best. That there's still a lot of things that they didn't have the data there that we would like to have stronger recommendations.
Absolutely. I'll go to Sheila because Richard spoke last, and I'll give Richard the last word. Sheila?
Yeah. Well, I'm hoping that, most likely this would be practice changing for me and probably with all my other colleagues. And apart from the shared decision making that Meral and Eric has mentioned, it's important that we individualize treatment and we listen to our patients. These guidelines are there to guide us, but it still boils down to what is important for both the patient and the physician.
Absolutely. And Richard?
I think it's a great effort. I kind of wish they'd been a little bit less prescriptive in certain places, but I think that nuance may come out when we see the full publication of the guidelines, and there may be a little bit more wiggle room there.
Absolutely. And I certainly commend Leanna and her colleagues on this wonderful effort. The number of papers that they identified in the literature search and had to cull through to come up with these evidence-based guidelines. It'll be very interesting to read the systematic literature review that accompanies these guidelines, as well as guidelines when they're published. So it's bittersweet. I've really enjoyed having panel discussions with all of you every day for the past 4 days now. But as we all move on into our practices and academic lives and everything else, I hope that we'll all stay in touch, and all of you as well stay in touch with us on Room Now. You'll be able to see this video as well. Well, you've seen this video, and you'll be able to see other videos about ACR Convergence 2020 on Room Now, as well as various summaries and lots of information keep up with Room Now, and you'll get your best rheumatology information on a daily basis. I'm Jonathan Kay. On behalf of my colleagues, goodbye.